Yes.
Dr. Thomas, I've got a handful of questions to ask you.
Mm-hmm.
First of all, what year was it when it was nationally recognised that cell salvage was effective and was a good thing?
It can't be pinned down to one particular year. It was a progression of practice and an adaptation of that practice. We give a range of times. I think that we published our data in 2001. That was mirrored by the Association of Anaesthetists booklet about withholding transfusion. And in 1999, Paul Herbert's paper, which was a randomized controlled study in critical care, showing that 9 grams was okay, that a withholding practice between 7 and 9, even for critically care ill patients, was safe. So it then spread over the next probably 10 years, finally driven home by the transfusion practitioners appointed after the 3rd Better Blood Transfusion initiative. So I can't be more precise than that, but I know that most large hospitals in Wales were using it by the end of the 90s, but across the UK it took a little bit longer.
And was there any guidance issued from anaesthetic bodies in relation to cell salvage?
We did a booklet similar to the red cell transfusion on intraoperative cell salvage. We included it in another booklet on massive hemorrhage, and the UK Cell Salvage Action Group produced a very heavy tome, which was all available on the URL that I gave you in my statement, giving one-sided A4 size sheets on how to set up the machine, how to use the suction machine, and all the recipes that you needed for successful use, included with a pro forma for a business case to go to Chief Executive asking for cell salvage machines.
And can you recall the date of your booklet?
The cell salvage one?
Yes.
I think that would have been 2007.
And can you recall the date when the UK Cell Salvage Action Group produced all that material?
Probably about the same time.
Around about 2007.
Late noughties.
How were audits of blood usage organised? Was it divided by department or by individual clinicians or by procedure?
By all of those. Departments were audited on their blood use, but that was of little value if you didn't drill down to the specific procedure. And then we looked at individual surgeons. It was anonymized initially. Initially, we based people's usage on a general departmental use for knee replacements, hip replacements, and so on. And that's what the MS-BOSS ordering schedule was based on. When we then got more information, we could say that individual operations required or did not require if they used cell salvage blood. And then we moved to a group and save rather than the MS-BOSS, where there was a specific number of units provided, to then drilling down, particularly in the orthopedic department, the 5 different surgeons that worked at our hospital. And they were anonymized by letter. And they soon wanted to break the code because they were so competitive. They wanted to show they were the best at not transfusing. And so it was easy then. And it would have been difficult to keep that anonymity in the freedom of information arena as we are now, that once you were collecting that data, it had to be released for public knowledge.
Were there any specialties who were repeat offenders of over transfusion?
Yeah, well, I hesitate to say this, but I have to say the cardiothoracic audits that we've done show a huge variation. In fact, you referred to the National Comparative Audit in Wales. There's one done of cardiac units in 2011, I believe, again supervised by John Grant Casey, and it showed a huge variation across the UK. I think it was 2012, of different transfusion instances between different cardiac units. So the variation is still there. The aim is to safely close that down so that we have a more predictable loss. But again, there's the weakness of audit, because one individual case we had a few years ago now was in big trouble, and we recycled 56 litres of blood. Well, you have one case a year like that, it means the departmental audit is meaningless. So it has to be actually statistically analysed. So we look at outliers, and he would have been an outlier. But he had that cell salvage. Of course, the blood that was being recycled was his own blood most of the time, or blood bank blood, but it reduced his overall transfusion need. I recently looked to see if that gentleman was still alive 3 years ago, and he was. So I think that was a great anecdote to try and persuade my colleagues on regular audit of blood use, because you would have assumed that something like that would have passed away.
And you gave some evidence in relation to the anaesthetist you saw giving 3 units of blood in the routine knee operation, and you described going into the operating theatre and chancing and coming across that. What was that an incident that took place before audit was in place? It was. It
was in the early days of about the same time as we were setting up the Hospital Transfusion Committee.
And did that prompt further audit and review of clinical practice?
Oh, undoubtedly. It in fact changed. It was after that interview I had with him, and he wasn't the orthopaedic surgeon, he was an anaesthetist, that we then instigated the randomized controlled study to show that there was no harm by withholding transfusion.
Those are the questions I have that I'm going to ask from call participants. So, do you have any questions?
Yes, I do. It touches on the theme of how you set about persuading others who were reluctant. You've described how you proposed being between the haematologist and the clinician and taking the bullets. So what did you do to stop the machine gun fire coming in your direction?
Well, there wasn't an awful lot of it, but there was less aggression shown towards me as a fellow clinician on the shop floor than from a haematologist who, obviously, we asked his opinion on transfusion issues all the time, particularly difficult coagulation issues, viral infections, but his interest was, at the time, drawn towards stem cell transplants and cancer treatments, and transfusion was something that we were all doing, and he wanted somebody more involved in that process to try and take a role, and I was more than pleased to do it. So then when you're working with people, you've got to work and dress in a theatre gear, you take all your suits and your fancy and your finery, and you're there at the shop floor talking about somebody's transfusion needs. It levels people considerably, and we've become reliant on each other's clinical expertise. And I think that was the key at the time, was that group working.
It's probably true of most professionals that some are very much more robust in sticking to their own view than others, or dogmatic, whatever word you want to use. From what you were describing, it sounded as though you come across one or two of those, not necessarily very many proportionately, but one or two in your time. Mm-hmm. Am I right?
Yes.
And how did you seek to persuade those who did not wish to be persuaded?
Again, in many instances, we would highlight clinical situations which were clearly either, in my view, a waste of allogeneic resource or an over-transfusion. I was aided by papers coming out showing that there were detrimental effects from transfusion, not just viral risk, but if a post-operative cardiac patient requires a blood transfusion, it has an impact on respiratory reserve. It may over-transfuse them so that they then go into what's called pulmonary edema or heart failure, and takes them a longer time to recover. And I think over the 6 years that I worked on the cardiac unit, I managed to persuade most of them that I was a safe pair of hands and that I would transfuse when necessary. And they did marginally change their views, the difficult ones, and particularly when you have evidence to show that there was no need for a transfusion, particularly things like platelet transfusions. If a patient is stable on an ITU and is not bleeding, if he has a low platelet count and is not anticipating going to theatre, there is no need to give a platelet transfusion to treat a number. And I had many occasions where I would refuse to transfuse platelets in that instance. And then I may do an invasive procedure myself, like a percutaneous tracheostomy, with platelets on standby in the blood bank, but not given to the patient unless they were necessary. And I think just little anecdotes and instances like that meant that they realized that perhaps transfusing to a number was not correct. You had to transfuse to a clinical need.
We had earlier in our evidence recently a strong support for the idea that nowadays, compared to as it was, clinicians tend to work much more in teams. And I imagine that's your experience, but tell me if it's not.
No, I think we do work more in teams. We're interdependent these days. People subspecialize quite a bit these days, and they know their particular area exceptionally well. Even these individuals that I'm referring to are exceptionally good surgeons.
Now, in a team involved in surgery in theatre, as between the surgeon and the anaesthetist, is it more the anaesthetist's responsibility to look after transfusions than it is the surgeon's?
They're integrally involved because there are perfusionists there as well, and very often the time that the surgeon wants transfusions given is when they're coming off the bypass machine, and at that stage there's a huge immune response, which often leads to low blood pressure, and that low blood pressure can be dealt with in a number of ways, not necessarily blood transfusion. And so it's that dynamic that there are competing interests, if you like. What has become apparent is that 20 years ago, all patients undergoing cardiac surgery would require blood transfusion. These days, we have a proportion of patients that come through that do not have blood transfusion of any sort and are very successfully dealt with. But they tend to be the more simplistic cases. The more complex the surgery, the more potential need for blood transfusion becomes. And so it remains a joint decision, but they're both in the same room at the same time with the same patient, so a compromise is often reached.
Thank you. That's all that I ask.
Do you have anything you wish to add to your evidence?
No, I hope I've been clear in my responses.
Well, you've been more than clear. You've been really very helpful indeed to us, particularly talking about your passions, cell salvage, limiting blood use, your advocacy of audit, your development of your pushing of hospital transfusion committees, and very useful as well in your insights into the practices of others, no names mentioned of course, into their use, or it may be misuse, of blood. And I'd just like to thank you for that. It's been worth hearing.
Thank you very much.
So tomorrow we hear from Professor Dame Sally Davis in the morning and Emma Prescott in the afternoon.
Yes. Tomorrow
10 o'clock.